Are there any questions? Robin?
You may not wish to answer this, but it would seem to me that if these programs that we've been hearing about today come to fruition and burgeon and flourish, we're going to develop an awful lot of data. And there's been an assertion during the meeting that these sorts of activities should be private, people should not be identified. But at a meta level, it's going to give a lot of information about how units work, how hospitals work, how jurisdictions work. And I think many of the arguments that are used to say that we should do this also can be used to say the public has a right to know how their health district works or how their jurisdiction works compared with lesser states south of Queensland. Now, what we're doing here, we're designing a system which is designed not to talk to each other. Will the College of X system be able to talk to the College of Y system and aggregate data? So I guess my questions are, does the panel think that there is a room for using these data at a higher level? And if so, do we need to be thinking now about developing systems that will allow this data to be shared?
You'd like to have a go?
Oh gosh, I think we have to have systems that talk to one another. So one of the strategies, and it's only one, is Eportfolios as a repository of the content of the learning process, the outcomes, achievements, etc. So we believe that should have three layers: a public layer that is exposed for the purposes for which that is designed, a private layer for the learner, and a de-identified layer for the purposes of research and sharing. And I think one of the advantages, there's only 2 colleges in Canada. And we have all of the specialties and subspecialties and all the diploma programs and special programs under a single roof except for family medicine. And so, you know, in one sense, we have an intent. It's our ability to share with the regulatory authorities. We've been working on that, and with specialty societies who are the key, in our country, are the key driver for the educational mission and how things are going. What could they do to contribute? We have to collaborate on the data set, I think, to make this good. And we can learn from each other's systems. Even though we have different contexts, I think we have very common purposes.
Anyone else want to comment?
It just occurred to me, Robin, that this is an opportunity to ask what are the questions we would be trying to answer, and now is the time to be starting to think about that, and that way we could actually build in the necessary commonalities. But the nature of practice is such that there will necessarily be differences that need to be accommodated.
I think there will be generic commonalities and then specialty-specific things. And I think one of the things that we've thought about very carefully is not reinventing wheels. So we approached RACS for permission to use their performance assessment, but we did need to modify it to make sense in our practice. And then the other thing I think is that we decided not to add extra petals to CanMeds. We approached the Royal College for permission and went with the existing generic roles of a specialist. I think we need to be careful also, if we're talking about data systems, to think about why we're collecting data and what we're going to do with it. And we've made a decision at this point not actually to collect the results of the audit, but more that the audit's actually been done, that it's been discussed with a colleague and what the outcomes for the learner were of that, rather than actually collecting all of those data.
Robin, if I could also add, on Wednesday we had a workshop on Eportfolios, so collecting all this information together. And one of the things that came out was that as we start to think about these things, we actually need to think about the stakeholders beyond the colleges who might have an interest, whether that's regulators or health services, etc. And for funders, you know, whoever might have an interest, that the design of these things along the framework that Craig's talked about may require earlier conversations about can some of this stuff be used for multiple purposes? And one of the things that came out was a very early need for standards and definitions. But this is my limit of technology, but one of Ian Graham, who's I think here in the audience, had commented on that. So I think that conversation probably needs to occur sooner rather than later between those who think they might be interested in this stuff. Question here? Oh, question here?
Hi. John Myers, thanks. First, perhaps to Craig. Craig, this word has been used, stakeholders, and I think you got almost all the stakeholders onto the last slide. But I think it misses, you're doing one thing, which is making sure there is ongoing learning, and you said it's differentiated from regulation and other things. But essentially, in all of this, I believe that what's missing from your slide, and what's missing actually in the content here, is what is the goal for the patient and what is the purpose of medical practice? Yep. And in my view, which I published in Internal Medicine Journal 2007, it is patient happiness. Mm-hmm. Now, patient happiness depends on where they go and what they do. And that outcome is determined by the discussion between doctor and patient in a sacrosanct, trustful relationship. And the outcome is very individual. And to know whether or not someone's using Dacron or nylon, at the end of the day, may be fine for whoever's ordering the supplies. But what is important is that the patient gets the goal, which is defined at entry, and that they achieve an outcome which is consistent with it if it was correct.
Okay, thank you, sir.
So can you put that into the equation? And just sorry to Lindy, I enjoyed your flexibility.
I might just take that question, sir, because I've got some others. So, did you want to comment, Craig?
I think you're right that the patients have a stake in this. I think I've been a bit more concerned that as we want to focus, and I think it's our intent to focus on health outcomes and how patients' quality of care and the safety of the system within which patients are cared for, we're going to have to spend a little bit more time thinking about the teams and communities that collaborate to provide that care. We definitely, as physicians, have a role to play, but I think team as the focus of the educational mission and processes that we are talking about has to become increasingly more balanced to the individual.
Thank you. Sir, I'll take your next question after I've taken these because I'm aware of the time. So I think there was another question here.
Can I just say thank you? I think it's fantastic to have such a breadth of people together in one place. I was wondering whether you'd considered the fact that in a time-poor environment, which we all are, would you consider working so that the smart devices that we use enable us to automatically download our CPD? Most of us use smart devices that have the activities we're doing in our calendars, in Outlook, but every day we have to go and then transfer that into our CPD. We're all sitting here with devices, we're all reflecting on what we're hearing. We could do our reflection in our phones, in our Outlook diary events that should then just download. At the moment, I'm transferring to 3 colleges my CPD. It takes an enormous amount of time. If I could move my diary, it would be almost everything all in once.
Okay, who wants to answer that question?
Well, I think automation of the documentation burden of this is critical. We started with a BlackBerry app. It's a Canadian thing to do because it was a Canadian company, although they almost faded. But we have an iPhone app that has already had 10,000 downloads. People are using it regularly. So you're right, tablets, smartphones, and the integration of other tools and that are portable with us as we go from place to place, critical that you can whip out and you've got access to the tools that you're reporting on and using for learning in one place, using multiple strategies. So I agree with you.
Thank you. Mindful of the time, I'll take a question over here.
Okay, I'm YK Chan from Malaysia. Sometime in 2004, Nicola Cooper, who is actually the author of Essential Guide to Acute Care, highlighted the fact that medical training did not teach her what she really needed to know. In other words, there are lots of graduates and also postgraduates who are not job ready. And I think we believe that some effort should also be put into validation instead of revalidation only. What are your thoughts on this?
Okay, validation before revalidation. Who'd like to attack that one? Richard.
I can have a go. I mean, with my previous life hat on as a leader in undergraduate medical curriculum, I think that point's been made over and over again, and it's one that everybody struggles with. The first thing is that in what is a young adult learning environment, there is a tremendous responsibility on the trainee and the student initially, the trainee subsequently, to ensure that they get an integrated set of skills, and our job is to help them do that. The trouble is that many of them focus on the learning content and take a didactic, content-focused approach to learning and get surprised by what they then experience when they reach their significant role. So, of course, you know, that's what in Australia the pre-vocational curriculum for early postgraduates is about, is making sure that they've developed and they're assisted to learn those particular skills. But some of those educational deficiencies hang on. And Craig has written an important review, which was, what, 2010 medical teacher, Craig,
Yep.
is that right? About competency, and it's the underpinning of competency by design. And it goes to the very heart of exactly what you're saying. And I think some of that's about having the appropriate expectations that, you know, we mustn't just tell our students and our trainees that it's about learning the facts, that it's about learning the role, understanding the role and integrating that. We have to help them along the way, but finishing that off is one of the really profound responsibilities that the learner has to make sure that they understand that and they take responsibility for that.
Last quick question from Lindy, comment from Lindy.
I think we've just gone through this process with our competency-based curriculum, and the key really was making the non-medical expert roles explicit and assessed and so on within the curriculum, or learnt and assessed within the curriculum.
Thank you. Now, one of my KPIs is to get the next session to start on time. It was supposed to start a minute ago, so I know there's still a couple of questions, but I'm going to have to call this to a halt. It's 2 minutes now, so I'm really failing my KPI. So I'd like you to join me in thanking the panel.
Who did your